it's not really an infographic, but it's a great graphical representation of how the acronyms tell you about the disease state and actually help you with the diagnostic criteria. So, you know, here comes the count. C is for let me do who does the alphabet? Count does numbers, right? Who does the
Well,
alphabet in Muppets or in
they all in
Are you
Sesame
trying
Street?
Street, they all
gosh.
do.
There we
You
go.
guys are
All
trying
right.
to make a
But
Muppets joke? You guys are just too much for me.
Well, this is getting edited out, so I don't really care.
Cookie Monster says C is for cookie and cookie
Yeah,
is for
right.
This material is for reference and educational purposes only. SimKit, its authors, and associates assume no responsibility for the utilization of any knowledge, materials, or techniques shown or described, nor do SimKit, its authors, or associates assume any responsibility for patient safety or outcomes. Clinical experience as well as current guidelines should determine the exact procedure and processes in each individual patient.
Hello, hello, hello. Welcome to the SimKit podcast. My name is Dylan War, and I am super excited to have the opportunity to co-host today with none other than SimKit's own Dr. Jason Hine. Together, we get the chance to talk to the endocrine extraordinaire, Dr. George Willis. We had such a great conversation that we needed to break our discussion up into two podcasts. The first will be on epidemiology, pathophysiology, and the clinical presentations of DKA and HHS. In episode 2, we will talk diagnosis and treatment. In both episodes, we base our discussion on the recently released ADA 2024 consensus report on hyperglycemic crises. Enough of that. On to the show. This is going to be a sweet treat for you guys today. We are going to review DKA and HHS. The goal here is to elevate your game in the management of this bread and butter emergency medicine diagnosis. And we're going to anchor our discussion in the recently released ADA 2024 consensus report on this clinical condition. Our goal here is to give you some insight into the latest recommendations on the management of these critical presentations. We are super excited to welcome Dr. George Willis to the show to help us master these presentations. George, thank you for being here.
guys. Thank you for having me. It is absolutely a pleasure to be here. It's kind of sweet, sweet to talk about DKA. So I'm super excited.
Yeah, I was gonna say, Dylan, I'm a dad, but sweet treat, bread and butter. I think we can come up with a hopefully a little better punchy jokes for this pod. But super excited to have you on, George, and 100% agree. Endocrine extraordinaire. Happy to be picking your brain on this topic.
If I can't make us all laugh and shame about how bad that was, I'm not doing my job, right? All right. See, I was gonna make some more jokes, but we'll just cut to the chase then. So George, tell us about this new consensus statement released by the ADA in 2024. What excites you most about these guidelines, and what can our listeners expect to take away from our discussion?
So first and foremost, thank God they finally released a new set of guidelines that we can use for this diagnosis. We have been basically basing all of our medical care on the 2009 guidelines. And here it is 15 years later, despite this mound of research that's out there, we finally have some updated guidelines that incorporates a lot of this literature that a lot of us have been using for a number of years that we're going to really hit home and hammer during the discussion today. So the first thing that I want to say is thank you. Thank you for putting these new guidelines out. And the thing I really like about these new set of guidelines is that they also incorporated all of the other big diabetic professional societies around the world. So Britain's, Canada's, a lot of these big professional diabetic societies got involved with this consensus report, which I think is super important. And some of these guidelines, these other countries have actually already incorporated into their practice. And so these guidelines were not necessarily updates for them, but certainly for us, this was a significant update. The fact that there's a new set of guidelines, two, that the diagnostic criteria allow for the diagnosis of euglycemic DKA, and we're going to really hit home about that. And then finally, the most important thing, which I think is critical for this diagnosis and for HHS, is that these new guidelines make up-to-date recommendations on the management of these patients, some of which are new, some of which I've been practicing for a long time based on really good evidence, but I'm really excited that they've incorporated these new treatment management guidelines. So I'm super excited to talk about this today.
I'm glad that the ADA has finally not only caught up to every other society, but to you, George. I'm excited to get into the nitty-gritty details today. So I guess to begin and frame our discussion, what is the state of DKA and HHS these days, besides it being a really common ED diagnosis? Why should we care about being masters of DKA and HHS management?
Well, it's not really a surprise that hyperglycemic emergencies are still very common. So, I don't go through a shift, even still today, I still don't go through a single shift where I don't see at least one hyperglycemic patient. I think the statistic that listeners may not be aware of, while DKA is still more common in type 1 diabetes and HHS is still more common in type 2 diabetes, there is this healthy incidence of the converse of that being true. And so we're seeing now some type 1 diabetics who actually can go into HHS. And on the flip side of that, as we know, type 2 diabetics can develop DKA, but we're actually seeing a higher incidence of type 2 diabetics developing DKA. And then the other big thing that I've known for a little bit of time, but that these new guidelines actually address, is that you can have patients who have a mixed picture. They can have HHS and DKA at the same time. And it's not rare. About a quarter of the time, this is what's actually happening. And so we really need to be aware that these two things are not always mutually exclusive. We can have incidences where both HHS and DKA are occurring at the same time. But the reason we need to be aware of this is because we see this diagnosis more likely than any other provider in healthcare. These patients are more commonly going to come to the emergency department for care. And so we really need to know how to, one, make the diagnosis, but two, also how to treat it and manage it appropriately. But the thing that we need to be aware of that I don't think a lot of people really know is that with every incidence that they come in DKA, their mortality continues to increase. Their long-term, lifelong mortality continues to increase. And so it's really incumbent upon us in the emergency department to adequately treat these patients and help prevent them from returning by providing good access to care so that they get appropriately taken care of when they're out of the emergency department.
Yeah, that's all very important stuff, and I appreciate your highlights in that area, George, about recurrent DKA and the increasing mortality. And the thing that I thought was particularly interesting was that in the consensus statement, they noted after years of decline in the rates of DKA and HHS, we're now seeing that these are starting to be on the rise again. And I was wondering, George, if you had any thoughts as to why that might be.
Well, I think there's a couple of reasons. One, we still continue to see an increase in the number of people being ultimately diagnosed with diabetes. While the trend had gone down kind of between the 2000 to 2009 range, and it had kind of leveled out in the second decade of 2000s, we've actually started to see an uptick in the diagnosis of diabetes, which could be related to the fact that we're recognizing it earlier. But I think a big part of the reason we are seeing an increase specifically in DKA and HHS is that medications have gone up in terms of pricing. Insulin is not cheap. I remember a time when insulin used to be relatively inexpensive, but in the grand scheme of things, we've seen pharmaceutical companies start to increase the prices, or we've seen a larger increase in the number of patients who unfortunately don't have insurance and can't afford to pay for their insulin. So as a result, we're seeing patients, especially type 1 diabetics, who are much more dependent upon insulin. They are completely dependent upon insulin in order to live. They know that. And so what they'll do is they'll actually ration their insulin. So they'll take it on day one. They will maybe watch their diet, maybe not eat as many high carbohydrate foods, try to drink more water, try to keep their sugar down. And then subsequently, maybe they won't give their next dose of medication that day, or subsequently even skip days of medication because they feel okay. And unfortunately, as we all know, is that these patients, although they may be giving themselves enough insulin to keep their sugar at least partially under control, it certainly may not be enough to keep the ketoacidosis at bay. This was unfortunately discussed in the consensus report as being the cause of 2/3 of DKA admissions in the urban minority patient population. So we are seeing a lot more, especially in urban populations and certainly in racial and ethnic minority patients, we are seeing much more DKA admissions due to being unable to afford their medications. Additionally, there's a correlation between diabetes and mental health. And so a large number of patients who have diabetes, and if you think about it, it makes sense. These patients have to stick themselves for finger sticks every morning. They have to stick themselves potentially with giving themselves insulin every morning. And it can certainly be depressing to have to deliver medications and be dependent upon medications, especially at a very young age. And so, as we see an increase in the incidence of diabetes, we certainly see a correlation with an increase in the incidence of mental health. And with mental health comes compliance with medications. And so, sometimes if patients get frustrated, they get depressed, they say, I don't want to do this anymore. They don't give themselves any medications or a lesser dose of medications. And so, I think there's a lot of factors that show this increased incidence and why it's occurring.
Ugh, I can just feel my blood boiling as we discuss the challenge of being a patient in our healthcare system. It's so frustrating for both us as ED physicians and our patients to navigate this clinical environment and this social context. And to read in this consensus statement that social determinants of health and mental health conditions are the strongest factors associated with recurrent DKA, it's just sobering. So we're taught in medical school, right, that some of the common causes of DKA, the I's of DKA, with insulin deficiency or non-adherence being right at the top, it's so much more nuanced and complicated than just, oh, the patient isn't taking their insulin. There's so much underlying context that we as emergency physician providers have to understand. So George, thank you for highlighting that for us and our listeners here. I guess other than not having insulin, we are familiar with some of those other I's that include infection, illness, injury, and ischemia. But George, do you have a different understanding of the precipitants of DKA since the last consensus update in 2009?
What's really important here to highlight is those 4 I's. We talked about infection, we talked about ischemia or infarction. So obviously thinking about myocardial infarction, thinking about stroke, thinking about mesenteric ischemia, which can look like DKA with the vomiting and the abdominal pain. And then insulin noncompliance. And one that we a lot of times forget about is pregnancy can do it. So I say the 4th I is infant, meaning pregnancy. But there's now a 5th I that I'm going to add in. These are medications that I was aware of, but I didn't really think about them as heavily as I should have. And I'm really glad that this new set of guidelines addressed this. And those are the SGLT2 inhibitors and checkpoint inhibitors, chemotherapy that patients with cancer may be on. And so the 5th I is going to be inhibitors. So we've all heard that SGLT2 inhibitors can cause euglycemic DKA, and we certainly need to be aware of patients on the gliflozin medications as being a potential cause of a patient being in euglycemic DKA. But I can guarantee you that not a lot of emergency physicians think about checkpoint inhibitors, and checkpoint inhibitors can cause a number of different autoimmune conditions and autoimmune symptoms and things of that nature. What I think a lot of people don't know is that it can actually cause an autoimmune diabetes in a patient who didn't previously have diabetes. And it's not a small number. 1 to 2% of patients who are on checkpoint inhibitors can develop an autoimmune diabetes. Now, 1 to 2% never seems like a lot, but if you saw 100 patients on a checkpoint inhibitor, 1 to 2 of them will have or develop autoimmune DKA. And autoimmune diabetes and subsequently can present in DKA. And the numbers, about 2/3 of patients who present initially with autoimmune diabetes have DKA on their initial presentation. And so I think it's really important to do a good medication reconciliation, especially if the patient doesn't have a previous diagnosis of diabetes when you're evaluating these patients who present in DKA.
That's helpful, George. And yeah, thank you for bringing up that extra I for the SGLT2 inhibitors and the checkpoint inhibitors. So something further to keep in our minds as we think about precipitants to DKA. I'm guessing that I've missed that. That's something to add to our repertoire when we're kind of trying to look for what could have caused the problem for the patient. We've talked a fair bit about DKA, and I feel like the ER doc, I love DKA. I love talking about it. HHS, not so much, maybe. I want to talk a little bit more about that and kind of peel back the layers of the onion there, which I feel like in clinical practice can be kind of a weirdly nebulous diagnosis or a hard one to pin down. So, George, I'm going to give you my understanding of HHS and you correct and add. How's that sound to you?
That sounds perfect.
All right. Putting myself in the hot seat with the endocrine extraordinaire. All right. So, HHS. I would say HHS is more common in the type 2 diabetic and the older person. That's the way I think of it. And I think of these folks as being insulin resistant, not without it, right? They have a functional pancreas that makes insulin, but our body's resistant. And so in HHS, when they go into that state, the AMP of resistance is gone up to 11. to quote some Spinal Tap. It's essentially just really profound hyperglycemia that the blood and the serum osms really can't keep up with, for lack of a better explanation. Now, again, the patient's making insulin, so there is this background insulin effect that's preventing ketosis. There's still some glucose uptake into the muscle and the fat cells. So glycogenesis is still happening, but the serum glucose level is like so high that dehydration is starting to happen, hyperosmolarity is starting to happen, and the brain gets pretty unhappy. George, how is that oversimplified view of HHS?
I love it. It's a really decent synopsis.
I'll take decent.
Yes.
Hey, that's a really decent.
It's a good enough synopsis, I think, for the big key here. But the key that people have to remember is sodium is the main offender here. A lot of people focus so heavily on the glucose. And the main reason why I bring this up is just recently, I mean, literally less than 2 weeks ago, I had a patient with one of my residents. The patient was in HHS. We admitted the patient to the ICU, and within 2 days, that patient was dead and gone. I mean, I went to sign the resident's note and said, "You are entering the chart of a patient who has died." And I was like, "What in the world? What happened?" There's no way that we didn't understand what was going on. But I think that the key thing to focus on here is that the sodium was not really looked at as heavily as we looked at it while the patient was still in the emergency department. And that was unfortunately what led to his untimely demise. So the key to remember here is glucose and water go everywhere together. And so when that hyperglycemia starts to occur in a patient who probably doesn't have a previous diagnosis of diabetes, or if they have insulin noncompliance, it is the reason why they're becoming hyperglycemic. As that hyperglycemia occurs and glucose enters the bloodstream and starts to proliferate in the bloodstream, that pulls water from the cells into the bloodstream and causes that pseudo hyponatremia that we oftentimes see with patients who are hyperglycemic. So the body has its own natural mechanisms of trying to lower the sugar to a normal level, the primary one being obviously insulin. But as we know, in patients, specifically type 2 diabetics who typically present in HHS, that insulin is resistant. It's not deficient, but it's resistant. So it's certainly not enough with these patients who have developed this insulin resistance. And so as a result, the second way that the body attempts to get rid of glucose is through the kidneys. And so it starts trying to excrete the glucose, which subsequently leads to an increase in the secretion and excretion of free water in the urine. If they don't replace that free water, the free water starts to leave the bloodstream, which causes the sodium to subsequently normalize or even be elevated in the face of the severely elevated glucose. And that's oftentimes the key to the diagnosis, is that these patients will have, the patient that I just had a blood sugar of 1500, which made my resident's anal sphincter tighten. But then we looked at their sodium, and their sodium was 129, which made my anal sphincter tighten. But that sodium of 129, if you correct it for that glucose of 1500, that person's sodium is now into the 140s, 150s, and even 160s. And so these are patients who certainly can present what classically presents like a hypernatremia. And we have to remember that sodium is the largest driver of the osmolarity. And that's what actually makes the brain unhappy, is that elevated sodium level despite the hyperglycemia. And a lot of times we miss it because we're looking on the labs for those red values, and that sodium level may be in that normal range with that severely elevated glucose. And so we completely look over the fact that that sodium is normal and subsequently miss the diagnosis. So that key thing to remember is sodium is not your friend with HHS.
Woof. You guys definitely are not just sugarcoating the complex pathophysiology of HHS. Thankfully, I'm going to have all the time in the world while editing this podcast to listen to this segment on repeat to really stuff this material into my brain. But everything in medicine really does boil down to physiology and pathophysiology. So that was HHS. I guess talk about the pathogenesis of DKA. What's different? What does the emergency physician need to know?
So the way that I think about DKA is DKA essentially functions like the patient is actually hypoglycemic. So they have glucose in their cells, but because they don't make insulin, they are not utilizing the glucose that's present. Now, how do type 2 diabetics who have a functioning pancreas and a functional amount of insulin, how do they go into DKA? Well, what happens in that circumstance is that these patients have an increased stress level, usually due to either the infection or the infarction, the myocardial infarction, the stroke, the mesenteric ischemia, whatever stressor is causing that type 2 diabetic to have an increased amount of cortisol. Cortisol, as we know, is a stress hormone, but cortisol's primary job in this scenario is to turn the pancreas off. It is telling the pancreas, don't make insulin in this scenario. So despite the fact that they can make insulin, type 2 diabetics don't make insulin in this stressed state. So essentially, insulin is no longer in the picture when DKA occurs. So what happens is, because the body can't use the glucose that's present and it thinks that it's actually hypoglycemic, the body secretes three things. It secretes counterregulatory hormones, and those three counterregulatory hormones that predominantly affect this are cortisol, as we just talked about, glucagon, and catecholamines. Catecholamines cause the flight or flight response. So they cause the tachycardia, the hypertension, the diaphoresis that usually comes with hypoglycemia. But glucagon is the biggest offender here because glucagon does three primary things. One is it stimulates gluconeogenesis. So essentially, these patients who are already hyperglycemic, now they're making more glucose. Couple that with glycogenolysis or glycogenolysis, I like to call it. So the breakdown of glycogen into glucose. So now we have two processes that are making glucose coupled with cortisol telling the body to not make insulin. And then you have the primary thing that glucagon does with DKA, which is tell the body to start breaking down free fatty acids and forming ketone bodies to feed the brain. Insulin does everything the opposite of glucagon. So glucagon's telling the body to do all of these things. Insulin's going to tell the body to stop doing all these things. So it'll stop gluconeogenesis, it stops glycogenolysis, and it stops the ketogenesis that causes the ketoacidosis. But in these patients, they don't make insulin. So as a result, they start to have a predominance of the ketone bodies being beta hydroxybutyrate, acetoacetate. The overpredominance of this causes the ketoacidosis. Couple that with these patients, because they are developing profoundly worsening hyperglycemia as a result of all the processes that are going on, they start to have the osmotic diuresis that comes about as well. And so these patients get dehydrated due to glucose spilling out, taking water with it. And so subsequently, these patients have two big processes that are making these patients sick.
Just listening to your commentary there, George, especially on the commentary of type 2 diabetes, do you have a sense of the timeline of when we should worry about DKA in patients with type 2 diabetes? I guess I remember my understanding in medical school was you have type 2 diabetes, and because of your insulin resistance over time, your pancreas is making insulin to try to keep up, and then suddenly just gets tired. And that's sort of like the end game of type 2 diabetes. Do you find DKA is more common only in people who've had type 2 diabetes for a longer period of time? Or can it happen before their pancreas, quote unquote, tires out?
It can really honestly happen at any time. It usually, so for instance, if you have a newly diagnosed type 2 diabetic who subsequently has like a very mild infection like strep throat or something like that, can we expect that patient to develop this profound DKA? Probably not. However, there are lots of case reports out there of newly diagnosed type 2 diabetics who've developed DKA from a heart attack or from an overwhelming pneumonia or even a urinary tract infection. There are cases of type 2 diabetics who develop DKA from Fournier's gangrene and overwhelmingly bad infections. But in the grand scheme of things, the key thing to remember here is from a timeline perspective, one is it can happen at any time, but two, it still happens relatively quickly. So these patients don't get Fournier's and then 3 days later go into DKA. They get Fournier's. That increased stress response happens relatively quickly, usually within a couple of hours, and then they subsequently go into DKA as a result.
And I think that makes sense if you think about a lot of the things you mentioned in the pathophysiology that I tried to forget a long time ago. So thank you for bringing that back up, George. But like the time frame and effect of the hormones involved in the axis of stress response, they're going to occur relatively rapidly. Some of the effects I think of cortisol are going to be more delayed and drawn out. But if we think back to what you mentioned and said so eloquently about the cascade, that's going to happen over a relatively rapid time frame, like you said. So it kind of ties back into the point you made initially.
100%.
All right, so we've been hinting at it, so let's dive into it a little bit here. One of the relatively new kids on the block since the last consensus statement is this increased awareness of euglycemic DKA. We've talked about pathophys for HHS and quote unquote classical DKA, but George, what about euglycemic DKA? How does that happen? For which patient should I have this on my radar?
First off, it's probably not going to be on your radar. But if you have a patient who comes in with an anti-gap acidosis with a normal glucose and they've never been diagnosed with diabetes, there's something else going on. It may be alcoholic ketoacidosis. It may be hyperemesis. It may be starvation ketoacidosis. We talk a lot about the SGLT2 inhibitors causing this. So that is obviously one mechanism. Another mechanism, though, that we are seeing a lot more of because we have a large number of population of patients who don't have insurance is that patients who are rationing their insulin, as we talked about before. And so they feel themselves going into DKA and say, I know that insulin fixes DKA, so I'll just give myself 10 units or 15 units of insulin because my blood sugar is 400 or 500, and that will get their sugar down, but it's not enough to actually stop their ketoacidosis from occurring. So these patients will come in with a relatively normal sugar, but still in diabetic ketoacidosis. Another patient population is our malnourished patients who don't have the liver stores to break down glycogen into glucose or to start the process of gluconeogenesis. And so this is a very similar mechanism to what we see for alcoholic ketoacidosis. And so your alcoholic patients, your malnourished patients, those are patients that you also need to be aware that euglycemic DKA can occur. And lastly, we have to remember pregnant patients can come in DKA, and oftentimes they come in with euglycemic DKA largely because they have a parasite, and that parasite is called the fetus. The fetus sucks their glucogen stores, sucks their glucose stores. And so these patients come in DKA, but their sugar is relatively normal because the mother's primary source of sustenance for the baby is their own nutrition. And so they can come in euglycemic DKA. So those are the big patients where I think about euglycemic DKA.
Man, George, I was hoping that you would just say something a little simpler. You know, we're wrestling with this new topic and this somewhat hard to get the pattern recognition down for euglycemic DKA. And I was hoping it was just going to be like, yeah, you look at their med list, and if there's not a Flozin on it, then you can stop thinking about this. But that's not the case, right? So we're
Nope.
going to think about our Flozins. But then you also mentioned the malnourished, the anorexia nervosa, just the chronically malnourished patients,
Yep.
the alcoholic or the cirrhotic patient. It kind of fits into a same camp of the poor stores of glycogen for use. And then finally, the pregnant patient. So the Flozins, the malnourished, alcoholic, and pregnant.
Low socioeconomic, the patients without insurance who might be rationing.
So that's a good point, and that's something to think about when the patient comes in. That is a question that our listeners should probably just ping in our brains is how have you had access to insulin? Have you used your insulin? Has there been any insulin noncompliance? Questions that we're always asking, but asking specifically, have you been rationing and when was your last dose? Did you give it to yourself right before coming here? That's an important question to really kind of pin down and get some of the details on.
Yeah, that's a really important point. It's actually a very critical question to ask. And a lot of times we sometimes just assume that patients have been non-compliant, which is a really unfortunate thing. And especially when they don't understand the socioeconomic factors that may be affecting your compliance. When you ask a patient, have you been taking your insulin? And they say yes, don't just assume that yes means that they've been taking it like they are supposed to take it. They may have been taking it, but not taking it as scheduled. They might not be taking it there 3 times a day that they're supposed to be taking it. They might have only taken it once in the morning and haven't taken it again until they take the next dose because they want to stretch that insulin over a period of time until they can get their next paycheck or until they can afford that medication.
Wow. I think the level of nuance there is really helpful to hear and think about as we approach our next patient, especially for those working in low access communities with patients who may struggle to afford medications and specifically insulin. I think about it too in the cases where my patients are housing insecure. Like, where are they storing their insulin? Do they have a fridge to properly store their insulin, right? For a lot of these patients, it's no, which makes them at much higher risk for quote unquote classical DKA and euglycemic DKA. I think, Jason, it's a little bit more than just Flozins based up our discussion here in terms of euglycemic DKA. So now I'm going to make this a little bit more complicated. I want to throw another wrinkle in there to you, George, that wasn't discussed at all in this consensus report. And maybe you can touch on specifically why that is, but where does diabetic ketoalkalosis fit in here? And for the viewers not nearly as nerdy as me and maybe us, what is diabetic ketoalkalosis exactly?
Diabetic ketoalkalosis is this newly identified entity, which has likely been here all along, but is just now starting to be recognized. So DKALK is the name that people are calling this instead of DKA, DKALK. And I'm hoping that this doesn't go from DKA and DKALK to being like, well, DKALK starts with an A as well. So now they're going to call it DKALK and DKAS. That's no.
You guys made fun of my bread and butter jokes at the beginning. That was pretty bad.
It was better than yours.
Fine. I'll give it to him.
So DKALK is the condition where ketone bodies are circulating and made, but alkalosis is the overriding problem with the acid-base status of the patient. So this can be because there is a concomitant alkalosis or alkalemic process that is occurring, whether that be a respiratory alkalosis or another subsequent metabolic alkalosis that's occurring at the same time as the DKA. But this can also be because the DKA has led to symptoms that can lead to the alkalosis. More commonly, what you will see in this scenario is these patients will develop DKA. Subsequently, they'll start having profuse vomiting as a result of the acidosis that's present. And that subsequent vomiting will cause a contraction alkalosis as a result of the vomiting that's occurring. Secondly, you could have such a profound element of the hypokalemia that occurs from that contraction alkalosis that they cause an increase in the generation of sodium bicarbonate and bicarbonate in the blood, which leads to increased aldosterone secretion, which will subsequently lead to further decreasing of the excretion of bicarbonate. So that bicarbonate will start to proliferate. And so it will mask the DKA that we typically will see because these patients will develop an alkalosis. They're going to look, they're going to smell, they're going to taste like DKA. But when you look at their pH, when you look at their bicarb, it's going to be either normal or there's even case reports of patients who have an alkalosis present. So they may have pHs of 7.5, they may have bicarbs close to 40. Those are patients where you don't want to say, oh, well, then you can't be in DKA despite what they look like. You have to think, could this person be in DKALK?
That's super interesting. And I might be showing my age here, but I feel like it's just like trying to put a name to something. Like you said, it's stuff that's kind of already been out there. For me, we're kind of renaming something that precipitated the DKA and you have it as an alkalotic state. Or as you mentioned, the DKA is causing a sequelae of vomiting or other processes that's leading to an alkalotic state. So it seems a little, I don't know, maybe I'm thinking a little curmudgeon-y, like, oh, this is the trendy new idea to bring up and just spin stuff we already have and know. But I recognize it and I value it as a point to say, when someone, like you said, looks, smells, breathes like DKA, but you're getting a normal pH, think about DKALK, which I'm throwing in air quotes and throwing a little eye roll at possibly.
I love it. No, I agree with you, Jason, in that I think in the grand scheme of things, I think the reason why people are giving this one a little bit of credibility is if the DKA is causing the alkalosis, then they're saying, well, the DKALK is its own process that's occurring completely unrelated to any other subsequent process. But I agree with you in that contraction alkalosis, yes, it's being caused by the DKA, but at the same time, if the patient wasn't vomiting, they wouldn't have the alkalosis. So, but they would still be in DKA. So technically, they're two different things happening at the same time.
Yeah, right. Exactly. Thank you.
All right, let's switch gears. We've gotten way too nerdy about pathophysiology here, and let's just get to bedside clinical medicine. Us ER docs love to consider ourselves experts in nailing the diagnosis of DKA, but we can obviously learn more. So George, what pearls do you have for us ER physicians regarding the presentation of DKA and HHS?
So I think the big key here to remember is, one, with DKA specifically, acidosis is predominantly going to be the thing that causes the patient's symptoms. So these patients oftentimes will come in with abdominal pain, they will come in with vomiting, And typically, because of the respiratory compensation that comes about as a result of the metabolic acidosis, they will have some tachypnea. Obviously, the respiratory rate is almost always the first vital sign that I look at, because it's also the one that's frequently fake. So I will typically look at that one or calculate it myself. If I walk into the room and I look at a patient and they look like they're breathing fast, I'll look at the patient's respiratory rate on the vital signs and I'll update those vital signs so that the patient actually has a true vital sign. If it starts to get profound in terms of the acidosis, so as you start to see those pHs of 7.1, 7.0, and lower than 7.0, they may start to manifest some symptoms of altered mental status. Once they get down less than 7.0, they can actually present into the stupor and the comatose state. And so we certainly want to keep an eye on their mental status as well. In terms of HHS, again, being that the predominant thing that's causing these patients to be in HHS is the sodium, the way that the sodium affects the central nervous system is going to be the thing that kind of seals the diagnosis. If their mental status is starting to waver and you start to see that sodium, again, being closer to normal, and certainly this is one of the situations where I do calculate what their true sodium is. And if their sodium, after I calculate it, falls into the normal range, HHS is less likely. If it's elevated, then HHS is very likely to be the diagnosis in a patient with altered mental status. Unless they tell me 100%, doc, I've not been taking my insulin like I'm supposed to. I know that I'm supposed to, but I haven't been doing it. I cast a wide diagnostic net to look for, is there some kind of stressor that put this person in DKA or HHS, especially if they're telling me that they've been compliant with their medications and they look like they're reliable in terms of they've been taking their medications. There's likely to be some stressor that's causing them to be in DKA or HHS.
I'm glad that this is kind of brought up and to hear George pontificate on it and tell us what are his triggers and thought processes, because we're recording this podcast in the winter and we're in the thick of kids being sick, right? We're in the thick of URI, norovirus is super heavy right now. And during that time, I see a fair bit of unexplained tachycardia in kids. And it makes me think certainly about, new onset or new diagnosis DKA as a sneaky possible zebra diagnosis, but one that I definitely don't want to miss. But I just want to ask you maybe more bluntly, George, when I'm asking for blood sugar on that URI kid who has this unexplained tachycardia, am I just being a pain in the ass to the nurse and just being a terrible person that makes kids cry by poking them and, poking their fingers unnecessarily? And more specifically, when should we be considering new diagnosis DK in the pediatric population?
So the first thing I do is I look at their vital signs and I look at their temperature. And I know that we harp on the fact that a temperature is not a fever until it's 100.4, but kids don't feel that way. When they're 99.1, they still will oftentimes have the tachycardia that's associated with a fever. And so if I give them some medication to treat what parents like to use was the low grade fever, I will give them some ibuprofen or some antipyretics, and I will get their temperature to where it's normal and see if their tachycardia responds. And if it does, great. Does it mean you've ruled out DKA? Certainly not. But in those patients where the tachycardia is coming down or normalizes, I'm not necessarily checking a finger stick in those patients. The acidosis that's associated with DKA will cause the vomiting, but we see that a lot in the viral illnesses as well. But the tachypnea is usually the first thing that I look for is the patient tachypnic. Now, obviously, we can see a lot of tachypnea with patients who come in with upper respiratory symptoms. And so when they come in with RSV, especially, or other viral URIs, they will have the tachypnea, but they won't necessarily have the retractions that we do see very commonly with RSV, bronchiolitis, and other viral URIs, especially if they have some type of obstructive process either in the lungs or, as we commonly see with these upper respiratory infections, the nasal snots, the rhinorrhea that causes these patients oftentimes to have their distressive breathing. So if I've cleared out, suctioned out their nose really good, or potentially given them a neb, and I've cleared their lungs and that tachypnea is still present, that's a person who I'm looking at potentially might need a finger stick at least to see if they have DKA. And then the vomiting with URIs is very common, but it usually corrects with a dose or maybe 2 doses of ondansetron. So if they get the ondansetron and they're running around the room, having a good time, that's not a person that I'm probably going to do a finger stick on. But if the Zofran or the ondansetron is not working and they're persistently vomiting, you have to think outside the box. So the other thing to remember is that typically when patients are in DKA, especially new onset DKA, they're oftentimes going to have elevated blood sugars, and that triggers the body to say, you have enough glucose, so you don't need to eat. Patients may get the Zofran, may feel better from a vomiting perspective, but you try to give them a PO challenge and they're like, no. They look at you kind of like, I don't want a popsicle. What kid turns down a popsicle? If they're turning down the food, even after the ondansetron and they're not vomiting anymore, but they're still turning down the food, think about, could this person have hyperglycemia? Does this person warrant a finger stick? So if these scenarios are occurring, at least get a finger stick. And if you're thinking about a finger stick, a lot of times I will oftentimes just go ahead and get further labs. So the finger stick's a really quick way. If their finger stick is normal, then you're kind of done. If the finger stick obviously is elevated in any way, that's the time to go ahead and get further labs. I don't like sticking kids with an IV if I don't have to. I always tell my nurses, look, if we don't have to stick a kid, let's not do it. But don't be scared to do the right thing in a sick kid.
That totally makes sense. And I like that kind of combination and thinking about, it's almost like a Venn diagram in my mind, right? We have that respiratory, we have that GI. And if you take those and you put them together, you got DKA right there in the middle of that. Oftentimes with the vomiting and the tachypnea, when you have a URI, you have a low grade, quote unquote, fever, you're going to bring that temperature down. You should clear the snot. Hopefully that tachypnea resolves. They're not having any GI effects. But if you see that kid with the norovirus who's just been vomiting and they're tachypnic, another big red flag, flashing light to think about some of these alternate diagnoses, particularly DKA. So cool. Thank you for clarifying that and helping us think through it.
All right. What a whirlwind. George, thank you for hanging in there with us as we tried to osmose some of your endocrine expertise. In this first part, we talked about the state of DKA, HHS, the pathophysiology of these conditions, including variants such as euglycemic DKA and DK-ALK, and the nuances of presentation. Before we dive into part 2 of this podcast, where we will focus on diagnosis and treatment, let's recap. The ADA updated their guidelines in 2024 in partnership with several other international organizations, the first update since 2009. In this age of overpriced insulin, some patients are rationing their insulin use, giving enough to decrease their blood glucose, but unfortunately not enough to prevent ketosis. We need to ask our patients not only if they are using insulin, but if they are able to use it as prescribed. DKA can occur in both patients with type 1 and type 2 diabetes, especially those patients with serious stressors such as sepsis. Think about why the patient is in DKA, not only insulin deficiency or non-adherence, infarction, and infection, but also pregnancy and checkpoint inhibitors. Euglycemic DKA can result from insulin rationing or inadequate insulin dosing in patients with inadequate glycogen stores due to malnourishment, pregnancy, and of course, SGLT2s. Diabetic ketoalkalosis can result from another primary process or as a secondary process due to DKA. Think respiratory alkalosis from Kussmaul breathing, vomiting-induced metabolic alkalosis, and severe osmotic diuresis leading to contraction alkalosis. If it looks like DKA, don't be fooled by a normal or alkalotic pH. Look at their anion gap, check a beta-hydroxybutyrate, and trust your clinical exam. Sodium is not your friend in HHS. Beware a near normal sodium in the setting of severe hyperglycemia, as the corrected sodium level will be much higher. And it's this sodium level that contributes to the mental status changes and increased mortality of this diagnosis. Lastly, a quick pediatric pearl. If your child with tachypnea or vomiting for a presumed URI or GI illness doesn't respond to your treatment in a typical way, consider DKA. All right, that's it for this episode. Until next time, part 2, treatment and management. Stay sweet out there.